the Ayushman Arogya Mandir facility. So though all the Ayushman Arogya Mandir have not yet started providing the screening services, I would first request, my ask from the teams would be, during the course of discussion, if you could also discuss on the challenges that they are facing. Because during my field visits, I visited 24 states. My field visit, I find that some of the CHOs who were not providing, they said either they were not trained, or even if they were trained, they didn't have they do not have the confidence to do it. And some of the CHOs, they reported that though training has been provided, we want to do it, but public is not coming forward. I hope I'm audible to all. If anyone could confirm.
Participants cannot speak.
Cannot speak. So I am audible. No? Okay. Okay. Thank you. So what I would request is, if you could discuss on the challenges, how do we improve on the IEC part, the behavioral change communication part, where we convince the women to come forward and get themselves tested. So since under the NPNCD program for 30 plus population, NCD screening is to be done, which includes hypertension, diabetes, and the 3 forms of cancer: oral, breast, and cervical cancer. For women, we are mainly focusing on the breast cancer and cervical cancer screening. So in both cases, I have found that women don't want to come forward and get themselves screened. They only, when they have serious complications, then they reach to the facilities for treatment. Since this program, this disease is preventable, cervical cancer is preventable. So if we focus on prevention, that is the best strategy. So I would request that how do we strengthen that? We already have a strategy, but somehow it is not being properly implemented. So that challenge needs to be addressed. So that is the first ask from the team. Second, once identified, suppose we assume an ideal situation where all the CHOs are doing the screening properly, all 30 plus population are coming forward, and the women are getting themselves screened for cervical cancer, then what next? Those who need to be referred, where they find that it's suspected, so they have to then go to the higher facility where they can get the diagnosis confirmed, and then after the confirmation of diagnosis, the treatment. So the surgery which is to happen at a medical college or a tertiary cancer care center, that also continuum of care chain needs to be followed up. We have an NPNCD portal, but there mainly we are capturing the screening part. We start with the CBAC form entries, where all the vitals of the NCD the 30 plus population is being captured. Then the screening, those found to be suspect of having cervical cancer, they being referred, but then after that, we do not follow up anywhere. So one thing which we are going to do from the next cycle, next financial year, is now we are making ABHA ID mandatory so that we can track each and every patient. Then second, follow up on the continuum, ensuring the continuum of care, entire loop is closed. So we start from screening, then those referred, they will be followed up, whether they actually went and got their test done, whether they were confirmed. Once confirmed, whether the treatment was done. Anyone going to a daycare cancer center for chemotherapy, whether that is being followed up. So as you are aware, from last year, we started this daycare cancer center scheme. Though it was there earlier, we had limited numbers, around 360 odd daycare cancer centers we had. We have sanctioned 297 more. So more or less around 600 odd, 650 daycare cancer centers have already been sanctioned, out of which around 450 are already functional. So what we have to now focus is through we are also coming up with launching of the daycare cancer center portal. This portal will actually be a game changer. Through this, we'll be able to track each and every cancer patient. So NPNCD portal captures the screening, and then later on what we are planning is this NPNCD portal will be linked to the daycare cancer center portal also. So all those who are being referred to the daycare cancer center, first directly going to the medical college or the tertiary center where the surgery would happen, and then further for follow-up, if chemo required, if any other counseling is required, for that referral to the daycare cancer center under the aegis of the tertiary institute, because the tertiary institute would be the hub and the daycare cancer centers would be the spokes. So that would be, of course, for all type of cancers, including cervical cancer. So this part we need to ensure that each and every patient is tracked. For prevention, also we have a program of HPV vaccination. In fact, we are going to pilot it out because we are getting some vaccines from Gavi that we have already got, and we have done the training of all the states, all the officers, the medical officers, and we have also supplied the vaccines which we have received from Gavi to the state headquarters. They have been reached. Very soon we would be planning a launch for it, and then those dates would be communicated to the states. And then there the target is, since we are piloting it, we are basically first focusing on the 14 age group. So all 14 age group girls would be covered under that, and subsequently we will then further scale it up to cover 9 to 14 age group. So what I would request the panel today, all the experts are there, they would help the states to further strengthen the entire program. So first part is the prevention part, the screening, then early detection. Once detected, then ensuring that the entire chain is complete, that treatment, the follow up, everything is completed. And the ASHA worker, the CHO, all also should be aware of where the patient has gone for the treatment and where the patient has to come for follow up. So the entire group of people available, the health workers available at the facility should also be aware. Same applies to the medical colleges, the hubs, and also the daycare cancer centers. At present, what is happening, the biggest challenge is NP-NCD program of screening is running separately. The daycare cancer center, those that are running, they are doing it separately, and the tertiary institutes are working separately. None of them are talking to each other. So this is the biggest challenge today. That is what we are now bringing all three together under one umbrella. Through the NP-NCD portal and through the daycare cancer center portal, we would be then able to track each and every patient. So my request to the entire teams, because all state nodal officers have joined, all the district nodal officers have joined, you have to work out for your state. Every state will have its separate challenges. There are southern states which are already doing this integration. They already had a scheme of their state which they were doing. Many have converged beautifully with the NP-NCD program. But there are still states where even daycare cancer centers today have not become functional. So those have to focus on making those daycare cancer centers functional. Training of the medical officers for chemotherapy, that has to be done. Hand holding by the medical colleges. Many places, medical colleges are working separately. They are not hand holding, not providing the support. So those also have to be done. Now we have integrated all, and under the daycare cancer program, we are also providing additional manpower to the medical colleges, because medical colleges, they have many departments, there's a lot of rush. So they are not able to handle all the cases and enter them in the portals as we require each person to be tracked. So that also we are helping out by providing additional manpower, so that you can also monitor and then you can also handhold the respective daycare cancer centers. So this in a nutshell is about the program. What I would request now all of you is, one, how do we address the challenge of women not coming forward? So how do we improve the IC, the BCC, so that women come forward and get themselves checked? We are saying once in 5 years only you have to get yourself checked. And the main group which is targeted is 30 to 45. So you have to focus on that. Then second is, once they have done the screening, quality screening is second aspect which I would want to focus on. VIA is happening, but many places the sample collection or quality screening is not happening, so we are missing out again on people. So that is another requirement. Then once already identified, suspected, how do you ensure that the person is getting the right diagnosis done and the right treatment at the respective medical college or the tertiary center? That, and then follow up through our daycare cancer centers. So this is what I would request to focus on. And one additional in the prevention part, apart from the vaccination, what I would request, also lifestyle, because these are all related to lifestyle diseases. So how do you improve your lifestyle better? How do you have better health? So what all nutrition you need to focus upon, exercise, how your lifestyle you need to change. All those things also should be focused upon. Cleanliness, a lot of things are interrelated. So all these we need to focus on and ensure that how do we prevent cancer, not only cervical cancer, cancer as a whole also we need to work on. And but for cervical cancer, because women are the target group and the worst part is that being this society itself has ingrained something in every woman that woman is the last one to take care of herself. She has to first take care of the family, and that every family has this, be it a rich family or a poor family. So because that, from I think from childhood it has been ingrained, due to which women feels unless I have a big complication I need not show myself to the doctor. Whereas if it is a child, immediately he or she has a problem, you immediately take the child to the hospital. If it is a man, you immediately take him to the hospital. But for women, generally they don't complain, they generally don't themselves, they are not able to identify that there's a problem with them, and unless it escalates and becomes serious, they generally don't go to the doctor. So this is where we need to strike, and that's why we had this Swasth Nari Shashakt Parivar Abhiyan. You all were part of it last year when we had it for 15 days. It was very successful. That was the main aim, that every woman needs to be healthy. When a woman is healthy, the entire family will be healthy. And if woman falls sick, the entire family gets affected. So that was what we had promoted, and women came forward to get themselves screened. So that is what I would now again request, that we work together. All programs, all components, all facilities working in silos need to be brought together, so that we are able to track each and every woman, and those requiring treatment, we ensure that the right treatment is given, so that she comes out of the disease. And also prevention part also we need to focus upon, and early detection. So my best wishes to the entire team. I would thank all the experts who have joined online: Dr. Seema Singhal, Dr. Partha Basu, Dr. Nija Vatla, Dr. Umesh Mahant Shetty, who have all joined online, and I'm sure they will be able to delve upon all the challenges and tell in details to the entire country, where I think more than 500 participants have joined online. More than 2100 have joined online. When I just joined, I was told 500. So 2300 people have joined online, which is a very good sign that everyone wants to contribute. And my best wishes to the entire, all of you who have joined online. I'm sure you will take this program forward, and we will achieve our targets of reduction of, basically the SDG goal is by 2030 there has to be 30% reduction in mortality of all types of NCDs, including cervical cancer. So that is where we have to aim to be. In fact, our focus should be more on prevention than getting the disease and then focusing on treatment. So first focus should be on the prevention part. So thank you all, and my best wishes, since the NPCCs are on, so I have to rush. Today we have for JNK, so I have to rush for that. So the team would continue.
Thank you very much, ma'am, for your valuable guidance and for setting the direction for today's workshop. Ma'am has played a pivotal role in strengthening national programs, including NPNCD program. Thank you, ma'am, for your continued support and leadership. This is encouraging for more than 2,400 participants who have joined us across different parts of the country. Thank you so much, ma'am, once again. Yes. Now moving on to the technical sessions. Session 1, cervical cancer remains one of the leading causes of cancer-related morbidity and mortality among women in India, with marked inequities across geography, socioeconomic status, and access to services. I now invite Dr. Seema Singhal, Professor, Department of Obstetrics and Gynecology, AIIMS, New Delhi, to kindly take us through the burden, inequities, and risk factors associated with cervical cancers in India. Over to you, ma'am.
Yeah. Am I audible?
Yes, ma'am, you're audible, ma'am.
My
Please
slides
go
are
ahead, ma'am.
visible? Yeah. Thank you so much
Yes, ma'am.
for this opportunity. And after such a motivational words from Madam, I'll be talking on cervical cancer in India, burden, inequities, and risk factors. As we are all aware that despite being preventable, cervical cancer remains the major public health problem globally. As
Ma'am?
per the European, yeah, sure, yes,
Can you
yeah,
use press the use slideshow button on the top of the slides?
yeah. What kind of view is coming? Okay, okay, sure.
We are seeing the presenter view.
Okay, sure. Yeah. Is it better
Yes.
now?
Yes. Okay, ma'am.
Yeah. So as we are all aware that cervical cancer remains a major public health problem despite being preventable. And as per the as per the Globocan data, world over 6,62,000 cases were detected per year, and the mortality was 3,48,000. And the burden is disproportionately concentrated in low and middle income countries, with Asia alone accounting for 60% of cases and over 57% of deaths. India carries an outsized portion of this weight. We contribute 21% of new cases and 23% of deaths to the global mortality. This translates to approximately 1,23,907 cases and 77,000 deaths per year, which are attributed to this disease. And a stark disparity exists in 5 year survival outcomes between India and high income nations. While survival in the United States stands at approximately 66%, in India it averages 5 year at approximately 51.7%, which is significantly low. So, if we talk about the significant variations within our country as well, the national average burden is 223.8 disability adjusted life years per 100,000 women. We observe a distinct southern advantage where states like Kerala, they report the lowest national burden, which is approximately 115.2 Delhi's per 100,000. In contrast, the northeastern region faces a severe crisis. There, the Delhi rates match around more than 350 per 100,000 women, and states like Mizoram, they report the highest incidence rates in India. So there's a longitudinal projection. If we look into this graph, this shows that our burden is further going to increase by 2040. There is an expected rise of 54% to new cases and 61% to the mortalities. And hence, it calls for a critical need for concerted efforts to mitigate the rising case fatality ratios because of this disease, which is totally preventable. Now let's look at this age-adjusted incidence rates across the population-based cancer registries 2015 to 2019 data that was published, and it shows clearly that the rates are highestly maximum concentrated in the regions like Aizawl, Mizoram, and Papampure district, where the maximum levels are seen in the incidence rates, while in the northern states like especially Srinagar, Kashmir, the rates are lower. And this highlights that substantial within the country disparity exists in cervical cancer prevalence and emphasizes the critical need for targeted screening and HPV vaccination efforts for our country. And again, within if we look into the northeast region, yes, the disease burden is high, the incidence rates are high. But if we look into the survival outcomes, there is a 30% gap between the top performing urban registries like Ahmedabad, where it is like 61% is survival. On the other hand, if you look into the down part of this graph, the Tripura, it shows only 31.6% survival. This shows there's a disease burden is high, as well as there is an inequity to access to the treatment services and tertiary care services, which is like this gap is further widening because of that. And so there's a need to think and make efforts to improve these startling differences. The clinical trajectory of cervical cancer in India is characterized by a disproportionately high prevalence of locally advanced cervical cancers. So if we look into this data within the Asia as well, our burden of stage 2 and 3 cancers is 68%, which is kind of highest among all our neighbors, and which is kind of comparable with the South American, the Brazil, where it is 73%. So our cases are presenting at advanced stages. And if we look into the survival analysis, which was published, and in this particular period, it was observed that the 5 year observed survival analysis was approximately only 51.7%. And this was without this, comparing all the stages. On the other hand, if you look into the regional and distant metastasis, the patients who had these, the survival further fall down, it is 53% and 18%. And our patients, more than 60% patients would present in local when the disease already spread within in the local regional areas. Now, look it into younger population, 15 to 39 years of age. If we look into this population, it reveals a distinctive downward trend in cervical cancer incidence. Like annual percentage change was found to be like minus 4.7%, and this could be attributed to the basically the period effect and generational shift because of the improved economic status, standard of living, increased age at marriage, low parity, and higher uptake of screening. But despite that, we have approximately 7,107 women who have suffered from this disease in which was projected incidence. And more than 50% of these patients, they presented with local regional disease at the time of diagnosis. So there's a need for referral pathways are well defined to ensure screening, timely diagnosis, early detection, and treatment initiation. And this is not the only burden. There is a lot of collateral damage. Like every hour, approximately 120 children would lose their mother due to cancer, and that is approximately 1 million children per year. So, so a significant proportion of gains which are being brought about by decreasing the maternal mortality seem to be offset by mothers whom we are losing because of cancer. And we are effectively shifting the burden from maternal loss from obstetric complications to the preventable late stage cervical cancer. And if we look into this chart, that we are, I mean, the countries like us, like Asia, we are contributing approximately 48% of the cervical cancer, which are totally preventable and which can be detected early and the outcomes can be improved. This collateral damage is not only like they suffer from the orphanhood, but then also this analysis from 53 African countries predicted that every 100 women who die from breast or cervical cancer, 14 to 30 children would die as a result. And also there are potential consequences of this orphanhood from long-term impact on multiple dimensions like violence, increased violence, compromise in education, family poverty, and of course the risk of teenage pregnancies, which have their own long-term complications. Now, if you look into this comparative analysis of WHO Sierra region that reveals that India faces a significant burden with the age standardized rates of incidence rates of 17.7 and the mortality 11.2, and we do not have yet properly, I mean, I would say that integrated secondary prevention and modern diagnostic services are definitely lacking, but definitely we also lack an integration of the primary preventive measures in our programs. And there's a significant screening void. Like our phase of cervical cancer crisis can be defined by the screening void, where we are able to screen only 1.97% of our eligible women. If we look into the NFHS 4 data that reported approximately 29% of women which were being screened, and now in NFHS 5 it comes out to be 1.97%. Why does it happen? Entirely because probably one COVID, number two, it could happen because of other reasons as well, like when it was NFHS 4, they took the patients who had undergone only one per speculum examination. They were also included vaguely, but that was not the right way. And so the NFHS 5 data, which is showing us that there's a definitively we are far behind. That is 1.97%. It highlights a great implementation gap. So there are definitive structural inequities, and if we look into this, that based on the excess could be because of urbanization, socioeconomic status. So the people who are having better access, they are benefited by proactive prevention, early detection, and treatment initiation. Other hand, in rural areas, low socioeconomic status, their level of awareness low, access to vaccination screening is low, so there is late prevention. Symptom presentation, because of lack of awareness, they present late. There's limited access to the healthcare structures, so late stage diagnosis, fragmented care, financial toxicities, and poor outcomes, high mortalities, and high economic burden. So we have definitive, profound structural inequities. Could be geographical, prevention excess, rural gaps, awareness gap, education gaps, and overall there is a significant implementation gap that needs to be fulfilled. These diagrams are, basically they are showing that how the cervical cancer testing uptake is affected by the regions, by the rural urban gaps, and also by the socioeconomic status and the educational status. So if you look into the down part of this graph, the south regions, there is a significantly better uptake of cervical cancer screening, approximately 45 to 50 per thousand women, as compared to the other areas like north or central or east regions, where it is really low, approximately 10 to 15 per thousand women. And then if you look into the differences based on socioeconomic status and educational status, then better the educational status in the northern areas was better, better influenced, better uptake. However, in the south areas, it was not that much striking. Even the people who were not like in the best of the quantiles for their educational status or socioeconomic status, where they were also benefited by the uptake of screening services. So this is particularly showing that there is a relative inequality. So this relative inequality, if we look into this, that urban and rural areas, the relative inequality is definitely high. The index of inequality is definitely higher than the urban areas. And even in the, if you look into this region-wise disparities, then the people who are living in this the eastern region or the west region or even the north region has the highest disparity, highest relative index of inequality, whether it is based on the socioeconomic status also and in the educational status as well. South shows the least, and the central regions were also better, but east and north regions were having the highest rate of inequality. The rural urban divide, if we look into the screening data, 1.9% was a total screening uptake by NFHS 5, but urban 2.4% versus rural only 1.8%. And if we look into this down in this particular graph, then the Tamil Nadu and Puducherry, the southern areas of the country, they had less effect of this rural urban divide, where the outcomes were good. Even the rural areas, the cervical screening was better uptake. But if you look into the upper part, the north part and the eastern part, this was really bad. And then this divide was really more wide. Now, why does that? I mean, this I've already explained, that COVID and also the difference in the cervical screening approach was different in the NFHS 4 and 5, explaining the difference and the downfall in the two periods of the cervical cancer screening rates. Now, this particular figure basically shows that cervical screening in India is partially clustered. Persistently low coverage core regions, high coverage hotspots, and sharp distinct level inequalities do exist in our country, indicates that where a woman lives strongly determines her access to screening. Higher education significantly increased likelihood of screening. There was the lowest uptake amongst Muslim women, scheduled tribes and low education groups, and southern India has the highest uptake. Multiple cold spots were identified. Although if you look into this picture, even in the southern India, if you see, there will be multiple cold spots here. And worst was the eastern part of the country. So, wealth has been the big determinant, and for cervical cancer care, and wealth-based inequalities have been observed. And if you look into this is the concentration index based on wealth quintiles, and this is a line of equality. And if you look into its north, it is more distinct in north, west, and also sometimes in east, but south does not show that kind of inequality. So region wise, if we see, then once again the same thing. The south, it is kind of better. There's not much inequality, while in north and northeast, it is quite prominent and determined. And religion remains a major determinant in the Muslim women. When they were stratified based on the well-educated and less educated women, then the well-educated ones had a better symptom awareness, higher understanding, correct knowledge about HPV transmission, and much higher willingness for screening and vaccination. On the other hand, the less educated one had poor awareness, major misconceptions, and they were not much aware that it is a preventable cancer. So geography drives outcome in cervical cancer prevention in our country. The central gap, the low screening and high mortality in the central areas, and in the northeast areas is the highest. Delhi and Mizoram, the incidence is very high, and Tripura, the survival was lowest. On the other hand, there is a significant southern advantage. Tamil Nadu screening rates were 10%. Kerala, the Delhis were very good, 115.2 per 100,000. They were lowest, and survival was 58.8%. So the burden of cervical cancer, basically there's a marked regional inequity, as I've already explained. There's state level extremes are there, and burden rises with age. 60% of disability adjusted life years occur in women aged 50 to 74 years. And another thing, the journey of healing, the travel, the patients from there, they come and they do travel to reach the services. That also makes a great difference. If the median travel time was approximately 4.3 hours, so mainly by public transport for our patients to reach, and there's a high non-medical cost that is incurred on the patients. Median is approximately 870 rupees per visit. And 76% patients were unaware of nearby cancer centers, relying on peer referral. So this is like kind of problem challenges. There are many challenges that are related to cervical cancer: access, logistics and psychological barriers, the geographical barriers, financial and resource scarcity, travel related hardships, psychological and household disruptions, and healthcare referral deficiencies because of lack of this thing. And this has led to, I mean, financial toxicities and inability to reach to the at the required time. Now, a word about the risk factors. They remain the same: sexual and reproductive risk factors, early age at first sexual intercourse, early age at marriage, multiple sexual partners, partners with multiple partners, multiple pregnancies, early first pregnancy. The socio-cultural and hygienic factors: low socioeconomic status, poor genital hygiene, poor menstrual hygiene, illiteracy, and lack of awareness. Others include smoking, long term contraceptive use, and immunosuppression. And HPV fact sheet clearly tells that about 5% of women in the general population are estimated to harbor the high risk HPV at a given time, and which are important for causing the cervical cancer. And the smoking prevalence in our country is 1.7%. And fertility rates have come down now. Our total fertility rate is now only 2.3, so which is a good mark. And but the hormonal contraception use is 4.10. The women, the percentage of girls who are having sexual intercourse before 15 has increased to 8% now. So this calls for understanding the social structure of our community, and we need to take care of these high risk factors as well. So we need to understand the HIV and HPV, they go together, and the HIV positive women, they have a high risk of, developing cervical precancer and cancer. So, this is a study which was conducted on risk factors of cervical cancer among patients attending a tertiary care hospital, and they found that marital status, history of alcohol use, and early age at first intercourse, age at menarche, and parity more than 3. They were the important high risk factors for causing cervical cancer. So, I would conclude by saying that cervical cancer in India, uh, cervical cancer in India, just a minute, remains a major public health problem despite having the tools for prevention, screening, and treatment which are already existent. But access to prevention and secondary treatment is to be improved, and we need to work on it. And also there are significant local, regional, and wealth related inequities. They do exist in our country, and therefore we need to work together in a concerted manner to improve our knowledge, improve our awareness, and then work on to correct these factors. And elimination is definitely possible, but it requires moving from availability of care in cities to accessibility of care for every citizen. And thank you so much for your patient hearing, and I'll be happy to answer the questions if any. Thank you.
Thank you, ma'am. Thank you so much for your insightful presentation and clearly mentioning about the iniquities and the data rich. Thank you once again, ma'am. Moving on to the next presentation. Ma'am, we're really happy to inform you that at present, more than 3,000 participants have joined us across the country, including doctors, program managers, state nodal officers for NCDs, and all those, officials who are providing cancer care. So the message is clear that, as much as we can share the message and build capacities among the service providers. Now, moving on to the next topic, which is screening and early detection. Early detection through effective screening is a cornerstone of cervical cancer administration, especially at the primary healthcare level. I now have really the privilege and honor of inviting Dr. Partha Basu, who is the head for Early Detection and Prevention Branch IRWHO, to guide us on screening and early detection strategies for cervical cancers, drawing from the global evidence and implementation experience. Over to you, sir. Thank you so much for taking out time.
Let me share my screen. Can you see my presentation?
Yes, sir. It's very clear, sir. Very clear. We can hear you, sir. Please go ahead, sir.
All right. Good afternoon. At the outset, I thank the organizers for inviting me to deliver the talk. And those who are not aware of International Agency for Research on Cancer, IARC is the WHO's cancer research, cancer public health organization based in Lyon, France. We need to understand that that globally, the landscape of cervical cancer screening is changing. And especially again, an understanding has to be there that screening is a very complex public health program because it is just not delivering the test, it is taking care of the women, or for oral cancer screening, men and women across the care continuum, which starts from the generating the community awareness, inviting the population to screening, to ensuring that the screen detected precancers or cancers are treated. As Madam Patnaik very rightly said, that cervical cancer is an eminently treatable, preventable disease, provided we detect the disease at a precancer stage and make sure that the precancers are treated. So, keeping that in mind, we'll have to think about quality assurance of the program, about which I'll talk very soon. But let us take some of the terms that keep coming up, especially when I read through the operational guideline. There are some places it is mentioned population based, some places it is mentioned opportunistic screening. And we also hear about organized screening. So, what are these things? Population-based screening is more like what they do in European Nordic countries. Their women, they are identified from a database maintained with the general practitioner or other administrative database. From there, the eligible women are systematically invited and they are offered the test. So that is population-based screening. On the other hand, opportunistic screening is you create a general public awareness, make sure that women come to the clinics whenever, for whatever kind of services, they are offered screening, so long as they are within the eligible age. For India, the eligible age for cervical cancer screening is 30 and above. I believe it is also time to think about keeping an upper age, which should be 60 years or 65 years, or we may think about the WHO recommendation of keeping the upper age at 49. But that's a discussion that has to happen. But opportunistic screening, generally people think that it is of low value screening, which is not. I can give you an example. Morocco is a North African country. They have a screening program for breast cancer and cervical cancer. What they do is, first thing is creating the facilities. They have made sure that every primary health center has a nurse who is well trained, or at least a couple of nurses, because one nurse may go on leave, well trained to provide VIA and CBE. And they then, once the the mechanism of delivering the screening services, mechanism of delivering the diagnostic services, they are in place, they create a huge amount of public awareness around the month of October for breast cancer, for November for cervical cancer. And this is a very highly visible campaign with the top leaders coming up and on television, on billboards, and then we have actually measured what happens. We have seen that immediately after the campaign, there is a huge increase in the uptake of screening. And then gradually it comes down around January, February. But by doing this, they managed to have a 60% screening coverage. So opportunistic screening is definitely doable, especially in a country like India, but it has to be backed by two things. Number one, creating appropriate infrastructure, manpower, and then also creating a high volume, high impact population awareness. Now, I very strongly believe in India, we have the capacity to now switch from VIA-based screening to HPV detection-based screening. Now we have understood VIA has a lot of shortcomings. VIA definitely has given us an opportunity to start screening programs in LMICs, but now, especially country like India, we can switch to HPV detection-based screening and twice in a lifetime screening, no more 5-yearly screening. We should be screening women once. If the woman is tested negative, which will be like 95% or 92% of the women will be testing negative. Ask them to come back after 10 years, again negative, forget about cervical cancer screening. This will be actually hugely saving our resources. And especially look at this particular graph. You see that right at the bottom, there the line that is showing what happens to the HPV negative women. In 10 years, you can see none of them have developed any cervical cancer, and even none of them have developed any CIN3, which is the real high-grade precancer. Those who are positive for HPV-16 or HPV-18, nowadays almost all HPV tests, they give you the results, including our indigenously developed HPV test, about which Dr. Nirja will be talking about, gives results on whether this sample is positive for HPV-16 or HPV-18. These women, they have a very different risk. Their risk of having the disease at that time point is about 10% to 20%. 10 to 20% of them, they will have CIN2, CIN3 or cancer. But even if they do not have disease at that point of time, we have seen that over 10 years, you can see those who are HPV-16 positive, nearly 18 to 20% of them, they will develop CIN3 or cancer. So we cannot leave them. We'll have to make sure that we treat them. So that brings us to the issue of revisiting the Indian guideline for managing the screen positive women. We do HPV test. Those who are negative, forget them for 10 years. Those who are positive for 16 and 18, we offer them treatment. Because as you can very well understand, screening is all about preventing risk. And if we can do the treatment, we prevent a significant risk of CIN3 and cancer. Those who are positive for other types, their risk is much lower. So we can go for VIA triage. Those who are VIA positive, we go for colposcopy. Those who are negative, they can be retested about after 1 year or 2 years. Again, I will very strongly recommend here that those who are having lesion on colposcopy, we don't wait for histopathology, because biopsy is a problem in many settings, and the woman has to come back for the report and we lose them. So a woman who is HPV positive, who is VIA positive, who is colposcopically abnormal, again, the risk is so high that we should not let this woman go without doing treatment. So, and again, if we go for HPV detection test, there are many advantages. Biggest advantage is it is an objective test. You don't have to invest so much in training, retraining the nurses to do VIA. So one has to take the sample, and the women can collect the samples themselves. And our own study has shown that even in a very rural heartland in Rajasthan, 90% of the women successfully provided self-collected samples. But then we'll have to also think how these samples collected will be transferred to the lab. Now, from the point of view of lab setting, one has to think of what model works. There are two models. One model is what Turkey or many of the countries they have. Say, for example, in Turkey, there are 2 centralized labs, very well quality controlled labs. And all the samples are from the primary health centers or secondary health centers. There is a courier service. These days, we have all those Zomatos and other things. If they can arrange the delivery services, why can't we in a program? So the courier services bring the samples to the lab, and then the positive women, they are again sent back the results either through their health facility or even through the through internet or social media. So all those things are possible because of technology. And exactly like Turkey, what are we going to expect? So more or less what we have seen in Turkey. In Turkey, HPV positivity is 3.5%. In India, it is obviously a little higher, about 6 to 7% will be positive. If we just look at HPV 16 and 18, of those whom we screen, only 1% will be HPV 16 and 18. So we arrange for their treatment. And then for the rest, we'd have to think about VIA triaging. So that will give you an understanding what will be the volume of work needed. And another model can be, especially in the hard to reach areas, is a point of care. So you have the gene expert or the TrueNat machines already there. So there we can think of women come there, they provide the sample, they wait, and the result is generated in a couple of hours, and then we offer the management. And from management perspective, again, in our operational guideline, it says cryotherapy. It is time to replace cryotherapy with thermal ablation because it's so much simple. Battery-driven machines are available, and you don't need any gas, refrigerant gas, and the treatment time is much, much shorter and much more comfortable to the women. And we have done large randomized studies to show it is as good as cryotherapy. So cryotherapy should be replaced by thermal ablation in India. Now, coming back to the issue of, again, what Professor Singhal was also very nicely explaining, it is just not the test, it's just not providing the services. We need to think about the whole organization of the program. And again, we talk about organized program. It's not a binary that it's a program is organized or non-organized. No. Even India has many of the components of organized screening program. When I go through the operational guideline, the governance system is very well delineated. Who is in charge at central level? Who is in charge at the district level? Where are the services going to be provided? All those things are there. But then where is the gap mainly is, you can see in the blue, this is quality assurance. And quality assurance is very important component, as you very well know, for every public health program, especially for screening program, because screening can cause harm. We have to be understanding this. If we do, there are a lot of false positive tests. The women unnecessarily undergo evaluation, and there is a huge psychological implication. We do a test and then tell the woman, okay, go and find out your own place where you want to have treatment. That is wrong. That is unethical. We need to make sure that the screen positive women are appropriately guided to have free services, diagnostic and treatment services. So quality assurance, what do we need to improve the quality assurance of the program? We need a quality improvement protocol, which is not there in the operational guideline. Or a separate quality assurance program, and that to by cervical cancer screening program. I know it's a comprehensive NCD program, but then each site is different. Each cancer site is different, and it is very different from hypertension and diabetes. So we need a quality improvement protocol where we identify who is responsible for regularly reporting. It should not be like an NHFS reporting every 5 years. No. And then there has to be a set of key performance indicators to be measured. Coverage does not tell us anything about quality of program. We have to again understand this. It is the compliance of the screen positive women to further assessment and treatment is much more important rather than looking at coverage. I generally do not even look at the coverage. I look at compliance or the detection rate of the disease. And to get this kind of data, we need a health information system. And in India, we can boast of having the best of brains who can develop information system. They need the guidance. They need to be told what exactly we need. They need to be told what kind of data we should capture at individual level that will allow us to estimate those indicators, and those indicators should be compared with standards. Again, standards are important. For example, compliance to further assessment. If I straight away say our standard should be 100%, that's impractical. We'll have to see what is the current what is the current situation. If it is 30%, we say in next 2 years we'll improve it to 50% or 60%. So that will be our standard. So that is important to be put in. And even LMI, many LMICs are doing it. This is the dashboard from the cervical cancer screening program in Bangladesh on a real time. You can see how many have been screened, how many have been positive, how many have undergone colposcopy, how many have undergone treatment. So if Bangladesh can do it, why can't India do it? So we need to really think about it in our operational guideline for the program. So To summarize, policy-wise, if we move to HPV detection-based screening, we need to do a pilot. But then before doing a pilot, we have to make a decision. Are we ready to scale it up throughout the country or through at least through some of the states? That has to be taken care of. Then even some of the countries, what they have done, like Zambia, they have decided every year 10% of the women will be screened, and then they'll gradually increase that 10%. Next year will be 20%, next year will be 30%. So that is how incrementally they will increase their HPV screening. Protocol, as I said, it has to be made more practical and adapted to the HPV screening. Logistics is very important, especially if we go for HPV testing. We need to make sure the supply chain management, how the kits will reach the women, how the kits will reach the laboratory. So that we'll have to think about. Investing in capacity building is extremely essential. We should not take it for granted that the gynecologists in the medical college, they know colposcopy, they know treatment of precancer. Most of them, they don't know. I'm being a very dogmatic here. So quite a lot of investment has to be there for improving the capacity to do colposcopy, treatment, histopathology of precancer. We have excellent histopathologists across the country who can read cancer, but reading precancer needs a special training, and that has to be think about. And then again, having a robust system of data collection to estimate the key performance indicators for regular program monitoring, not once in 5 years or this thing. And that information should be published, shared with all persons associated with the program, and then only we can think of quality improvement of the program. And at IARC, we'll be very pleased to collaborate with the Ministry of Health, the WHO, to conduct a situational analysis. What is currently going on? Where are the real barriers? Where are the opportunities? And develop a context-appropriate evidence-based protocol with a quality assurance manual. Thank you so much for your patient listening. Thank you.
Thank you so much, sir, for those extremely valuable insights and for taking us through the global evidences and learnings. Thank you once again for taking out time, sir. Thank you. This is really useful for around 3,000 participants who have joined us across the country, and we can see most of them are clapping now. Moving on to the next session, which is again a very important topic on the comparative effectiveness of HPV DNA, via and pap smear, which test, where and why. And it's my absolute honor and privilege to invite Dr. Nirja Batla, Padma Shri awardee, an internationally respected expert in cervical cancers. She was former head at the Department of Obstetrics and Gynecology, AIIMS, New Delhi. She will take us through the comparative effectiveness of HPV DNA testing via and pap smear. Dr. Batla has made immense contribution to cervical cancer prevention, national screening guidelines, and policy dialogues, and has been a key voice in advancing cervical cancer elimination efforts in India and globally. Thank you so much, ma'am, for taking out time. Over to you, ma'am.
Thank you for inviting me for this webinar today, and it's really nice to see how many participants we have. And I'm sure the talks that have happened before have made my task much simpler. I'm not able to share my screen, so I will have to request you to share my slides. And some of them, unfortunately, are in animation, so we'll have to work with that.
No issues, ma'am. We will project from our side.
Lovely to see all these claps coming up. So today, my talk, which I think will deal a lot with what many of you already know, and hopefully will put it into the context into which it is currently, and what we are doing and how we should be doing and what we can do. And Dr. Path has already set the stage for that in a very, very lucid and clear manner. So yes, next slide. So I think all of us through our MBBS days all learn about pap smear. And we know from a long time now, from the very first study which came from Canada, from British Columbia, systematically done study which showed that doing the pap smear as a national program regularly and repeatedly could bring down the invasive incidence, which is shown in dots, which is the mortality, which is shown in a solid line, while taking up, on the other hand, the diagnosis of the pre-cancer, or it used to be at that time called cancer in situ. So, but note the use of the word that it is to be done repeatedly and regularly in a national program. Next slide. So this pap smear test, one of the reasons why it had to be done so repeatedly was that it actually, a single round does not have a very good sensitivity to pick up the disease. In a meta-analysis of studies, not from LMICs or developing countries, but from Europe and North America, it was seen that it was around 55-60% on an average to detect CIN2, CIN3 and worse, which is our definition of the high-grade cytologies. Next slide. So how was pap smear so effective? Well, of course, though the sensitivity is poor, but the specificity is high, meaning that if pap smear tells you it's normal, it may or may not mean that there is disease. But if it tells you abnormal, then there is a very high chance that there is disease and action is required. But the main thing, because various countries had different programs, either 1 year, 2 year, 3 year programs, and this took advantage of the long natural history of cervical cancer, which usually takes 10 to 15 years to develop into a cancer. So, in this long window of opportunity, if it missed the cancer once, or the pre-cancer, I should say, if it missed it, there was still the possibility that the next time or the next time it would be caught, or at worst it would be caught as a cancer but still at a very early stage, so that it would not have a mortality effect and effective treatment would still be possible. Next slide. So for us, actually, there was always the struggle of how do we set up this thing at a scale, because it required infrastructure, it required manpower at the doctor level, at the technician level, for the collection, etc. So there was always a question about funds. There was not enough awareness amongst people, and effectively, it resulted in inadequate screening. Next slide. The usual lament was preventable but not yet prevented. Next slide. And then came the era of the visual inspection techniques. Visual inspection with acetic acid, VIA, also popularly known as the vinegar test, because 5% acetic acid is really vinegar, and visual inspection with Lugol's iodine. But hereafter, I will talk mainly of VIA, because VILI, being an effective tool, still did not find its way into a program because of being more difficult to provide, more expensive to provide, and all. So, these tests, the good news was that the sensitivity was comparable or even better than pap smear. It was suitable for all levels of healthcare. We have successfully trained our ANMs and other health workers to do this. And the results being instant, 1 minute after application, you could consider defining characteristics for the screen and treat approach. You could take a biopsy and do the treatment like thermal ablation, now we are talking about, or you could do it even without if it met those criteria. So thereby the loss to follow-up was minimized. There was the use of magnification devices, what was called VIAM, which don't really change the test performance, but they do provide a good light source. Next slide, please. So you can see here some results from India, from Africa, which tell you how accurate the VIA is, and you can see that it varies from 55 to 83%. And there is definitely variation, not just based on that worker, but we have seen the same workers also. It varies sometimes based on the population or based on the time since they did the tests last and needed some recertification. So there is variability. But in good hands, it can also show very good specificity. Next slide. It's definitely subjective. Quality assurance is a concern. Increased inflammatory reactions may increase the number of false positives. And then you have this whole bunch of people who may have the disease. Any of the screening test being positive does not mean that disease. You have to have a triage tool to focus down now further which of these positive ones actually have disease. And there are a bunch of triage tools we have for this purpose. It's not really suitable for postmenopausal women because the entire transformation zone is not seen. It recedes into the canal. Although we have it in our national guidance for convenience, but not really. And there is insufficient data on populations which are at special high risk, like HIV positive women. Next, please. So, in an attempt to make it a little bit quality assured, Dr. Shankar Narayan and colleagues put out this practical manual which can be downloaded, as well as many other resources are there on the IARC website, which you can download and see. And we also have translations of this manual actually into some languages in India. And you can see that they have attempted to show various types of lesions that can be VIA positive or Willi positive to quantify it better. Next, please. Next, please. So these are our guidelines, which you are, of course, familiar with. They extend from the age of 30 to 65 years, though, as discussed, really beyond 50, they are not useful. The frequency of screening has been defined as once in 5 years. Again, can be and terms they don't see why they should work outlined. Next slide, please.
Ma'am, your voice is slightly breaking, ma'am. Hello.
Problem in the network. One more.
Now better, ma'am. Now better.
Next slide, please. Next slide. Yeah, so you are also familiar with this chart which has been provided as the the way the flow chart, the clear criteria, which again, as Dr. Patha said, focused at the time on cryo. Today, thermal ablation is the new workhorse. And also the conditions in which they should be directly recommended for further evaluation, because it may not be sufficient to just do only the VI alone. Next slide. So this was not something that we, we accepted this technique because it is feasible and affordable, but not completely without any basis. So there were good trials which have shown from Mumbai, from Tata, from Usbad and Dindigul, which were from IARC, and introduce and reduce cervical cancer and incidence mortality. But the only thing is that it requires to have the complete the complete end-to-end management, and as Dr. Patha emphasized, the compliance treatment. Next slide. And just the VIA is not going to achieve the result. So this was how it started. The implementation started with the breast and cervical cancer program in Tamil Nadu. Next slide. It started in one phase and then into another phase. And it was very clear how they would flow. No, this is a repeat. Next slide. And of course, when it came to the national level, there were the training modules, the operational guidelines. There were further refinements also, which have been put out since. Next slide. But really, the story of screening changed when the Dr. Harold Zurhausen showed that HPV is the virus causing cervical cancer. There are very few cancers which are caused by virus like hepatitis B virus causes liver cancer or some nasopharyngeal lymphoma and all. But this is one of the very HPV causes not only cervical but also some other cancers, cervical main one. After that, development of tests as well as vaccines. Next slide. So the HPV test actually started as a sort of a cocktail of types. Next slide, which have about 14 types, which are the most common. Next slide. And now we have a second generation of these tests, which have separate channels for the high-risk type 16 and 18 for sure, and sometimes other differentiation. So this becomes also like an inbuilt triage. And you can tell that these are the types which are more likely to progress, and we must give them treatment in even sometimes give a thermal ablation set if we don't see a lesion also, just because they are positive and we may not get them back. That's the type of indication we get from the 16. But very important, it is we have to have the standardized and validated tests that are available. Next slide. As I showed you that the cytology had a sensitivity which was low, here you can see that in the same meta-analysis, there's a huge difference. It is more than 95% sensitive. So obviously, this is the test we need to tell which are the women who are at risk. And usually it's 6 to 7% show up as positive when you do the screening. And these are the at-risk women whom we have to further look at. Next slide, please. And we have some data on the accuracy of these tests, which basically boils down to showing you that it is a variation again, but and the meta-analysis, it can go anywhere from 66 to 100%, but basically mostly hovers in the range of 85% or so with very good specificity. Next slide. And the study which was done by Dr. Shankar in Osmanabad was actually a landmark study. Just keep clicking on it, please. So this one was a large study, 4 clusters, 130,000 women. Just keep clicking. And in a single round of HPV testing, there was a significant reduction. But it was clear that until we have an affordable point of care test, we will have to stay with VIA. Most interesting was the follow-up of the patients, women who were negative. The ones who were negative on HPV testing had the least chance of developing a cervical cancer in the future. Whereas the cytology and VIA, you could be negative today on this test and still develop cancer later. Next slide. So this in a nutshell is how these tests work. Just please keep clicking. The pap smear and VIN really detect once there are lesions, whereas the HPV detection range goes all the way across. Next slide. Yeah, this is now showing you, just click again. I didn't even realize this one is an animation. As far back as 2013, the WHO guidelines declare that countries that have not already established cytology programs should not start to do so now, because it was realized that cytology has a place if it is a well done, quality assured, and with all these repeated testings and everything possible, it's a good test, yes. But to start putting it when we know that we have options that are better is not a good idea. Next slide. And in fact, in our Federation of Obs and Gynae Societies, we modified the WHO's recommendation to this one, which looks a bit complicated, but basically it says that if you are doing cytology, check that your lab meets the quality indicators. If it doesn't, think about doing HPV testing if you can. If it does meet the quality assured indicators, also think about whether your hospital or patient can afford the HPV testing. If you can't, then of course you can't. You continue screening with cytology alone, but if you can, you should switch to the HPV testing. Now, if you're doing the HPV testing, you have to further think about the triage, as I mentioned, which one way is to do the HPV genotyping, one way is to do cytology, one way is to do the VIA. And if you can afford the HPV test, if you cannot afford HPV testing, then you do VIA. So all the three tests are valid tests. Wherever you are, whatever you can do, something is better than nothing. And there are clear algorithms for managing them. Whatever you do, there should be a feasibility to do a biopsy ideally. But if not, there is still the feasibility of the screen and treat, and these should be built in. These are built into our national guideline also, as we saw, and these should be built in. So next slide, please. And we can just skip the next slide and go to the next. Just skip this slide. Yeah. So HPV point of care affordable tests are there already. We have the CARE HPV test from QIAGEN. We have the Gene Expert by Cepheid, which also has Gene Expert for TB. We have an Advantage HPV, not in India, and TrueNat HPV HR is our new hope, which is an Indian test by the same TrueNat TB testing, same machine. You can do this test. The cartridge is different. It's relatively affordable and cheaper than the other tests. And we have tested it, validated it, found it to be effective. And this is something which we are hoping now to do implementation testing, and we will implementation research and all that, and have it hopefully sooner rather than later into our program. Next slide. Now, the next slide is really animated. Just please keep clicking on it, and it shows you how our multi-visit approach to screening and treatment works, because you tell them to come and then you come again, get the colposcopy biopsy. If they need an ablation, come one more time. They need a LEAP, find another place to go to. And if they need a cancer treatment, then of course they go and multiple times. So the idea is that we should see how not to make the ideal the enemy of the good. And the next slide shows you that there are studies which have estimated, please click next, the value of a hypothetical point of care HPV test has been modeled here and shown, next slide, that it has an incremental net monetary benefit if it is a one visit approach, especially where loss to follow-up is likely to be high. Next slide. So the other big advantage with HPV is that you can do a self-sampling. The woman can take the swab herself, or somebody can take it for her, but don't require speculum, sterilization, light source. And WHO has in fact recommended this as part of all the self-care recommendations. Next slide. And again, just click again, please. This large study in Latin America had looked at a cluster randomized trial for screening uptake and found a fourfold increase if you were able to offer this self-collection to women at home by the community health workers. Next slide. We had done this way back in 2008. We published this, and we found that 98% of women provided a sample. We used this to sort of a chart to explain what they have to do, and there was a 94% concordance. Next slide. But again, though we're talking about the screening test, I do wish to emphasize that we have to keep looking for treatment. And if we don't treat them, then it's no use. So, and we do have many devices now, apart from the visual assessment, which is basically VIA to see that the lesion fits the criteria. But you also have mobile portable colposcopes, which can pick up the images and transmit them, or vice versa, that they can be linked. The AI can be now built in, and hopefully that will give direct answers. So I think in interest of time, we'll just go very quickly through the next 3-4 slides, which is just to show you that the kind of digital imaging approaches we have. Next slide. And we have extremely good sort of images that come from them, which are very comparable. Please keep clicking. Yeah, the next slide. And next two. And also by using the, we use the scores to decide on instant treatment. Beyond score 5, for example, the sensitivity is perfect, but beyond 8, if we do it, the specificity becomes very good. So the risk of over treatment becomes very low. Next 2 slides show the emerging treatment modalities also, which are very much coming up. Next slide. Various things which have been devised, which are now portable, battery charged. 2 battery packs come with 1 device. So let's go next slide and the next, and we'll come to yeah. So this is about the thermal. It's so simple, you know. It gets charged up in seconds, and you take it to 100 degrees. You take the appropriate probe, apply it for not more than 30 to 40 seconds, multiple approaches. I'm sorry to hear from several sources that the medical officers don't want to accept this assignment, which seems rather sad to me, because it's such a great opportunity to do a world of good by just doing this simple test, simple treatment. And as I already said, out of 100 women, 6 to 7% will be positive on the screening test. And out of that, maybe there are about 2% in total, maybe 1/4 of those women who will require this. It's not going to be a huge burden in work, but it's going to be huge dividends, both in getting the good points from the Lord above and from relieving the patient of her problems. Next slide. So this is our current screening coverage that you have, which is rather poor. And in spite of having started this program from 2016, this 2021 fact sheet shows 3% coverage, and we are not very much better. NFHS has not given much encouragement. Next slide. And the question of what ails our program, maybe you all can answer me better, but better than I know, but less than half or maybe half districts are covered, and the VIA coverage is the poorest. Oral cancer screening of whatever quality is the highest. Breast cancer comes next. Provider training is deficient. As I mentioned, we've had many cases on record of MOs refusing to do it, or system problems like transfers. The linkages are not there, patient navigation. There's so much load. I'm not denying that there's a lot of load of curative treatment, programmatic requirements, but we have to find a way. We have to find a way. Next slide. So this is just a summary of the WHO guidelines showing the various screening tests classified now as molecular, cytology, and visual inspection techniques. Next slide. And this is actually the guideline which is available free download on the net, and there are 7 algorithms for whatever method you have. They are all evidence based, and you can accept what you can do and follow it very simply. Next slide. The main thing to remember is the need to transition to HPV testing. Next slide. In fact, WHO has said this as far back as 2005. Next slide. And there is a lot of evidence that once you are negative on an HPV test or a co-test at that time when they did, that the risk is very low that you will develop a CIN2, 3 or worse. Next slide. And there's also evidence-based increase of the screening interval. So it was increased to 5 yearly. You see the cytology in blue line, they may be negative, but they can develop. HPV negative or both cyto HPV negative, very low likelihood of developing. And that is why WHO now says that if you do a validated HPV test, just 2 tests in a lifetime at 35 and 45 will be good enough. Next slide. We've been harping about the 16-18 importance, and this slide shows you why 16-18 is so important. Because, next slide, because it is the 16-18, the top 2, especially the women over 30. HPV testing is not really recommended below 30, because at that age, many women have the infection, but they are going to clear it out by themselves on their own. But the 16-18 is the one which are more likely to persist and progress, and we don't take that lightly. Next slide. I already mentioned to you that we have done the validation study for 4 indigenous tests. Next slide. And it was the TrueNat that has come out to be the very good one, in that it has the 8 commonest types, and it has met with all the international criteria, and we hope that we will be able to use this soon. Next slide. So that, as we have recognized, there are deficiencies to be addressed at various levels: health system, provider, community, gaps in implementation of screening and awareness activities that we have to look into. But certainly, next slide, we can end cervical cancer, and we must end cervical cancer. And this is the month, January, Cervical Cancer Awareness Month, 4th February coming up, International Cancer Day, March coming up, International Women's Day. Let's put our best foot forward. But most importantly, all of you, you are the ones who can make a difference in the national program. So thank you for this opportunity today.
Thank you. Thank you so much, ma'am, for such an insightful, practical, and clear explanation of various screening modalities, at various levels of care. It was really insightful. You can see the participants are clapping, and more than, 22 participants have joined. Thank you again for taking out time and for such a, engaging presentation. Thank you, ma'am. Thank you. Next, very, very, very important topic. It is HPV vaccination under Universal Immunization Program. Who can better explain and teach it than Dr. Pawan Kumar, sir? It's my privilege and honor to invite Dr. Pawan Kumar, who is the Additional Commissioner, Immunization and Maternal Health Division at the Ministry of Health and Family Welfare. He will take us through the HPV vaccination rollout under the Universal Immunization Program, including the strategies, the challenges, the opportunities from his national level experience. Over to you, sir.
Okay, thank you. Am I audible? Okay, so in next 15 minutes, we are going to cover a very important topic, that is regarding HPV vaccination. So in coming 15 minutes, we will be discussing about the overview of HPV vaccine, what the WHO position paper recommend, what is the global scenario, what are the different types of HPV vaccine available globally and locally, what is the dose schedule, what is the India experience, what could be the challenges and issues. So in that manner, we'll be moving forward. Since morning, we have discussed about the screening part, the tertiary care part, the global burden, the local burden. I will be talking primarily about the primary prevention, more specifically with the vaccination among the girls of 9 to 14 years, if it is being introduced in the program. So that would be a very important topic from that perspective, being if you see the 90-70-90 strategy, where we envisage that 90% of girls till 15 years of age, if they are immunized with HPV vaccine, and if 70% of the females, they are screened with high precision test at the age of 35 and 45. And the last 90 is that if we are able to screen and if we are able to diagnose, and then 90% of those women, they are being managed at the tertiary level or a secondary level hospital. So having said that, that is a continuous cycle for cervical cancer prevention and control and elimination strategy for the country. So before moving forward, I want to give you kind of a risk which different variants they bring. As Madam Bhatla was telling about the 16 and 18, they are the most culprit variant, which amounts to 77% of cervical cancer. And if we talk about more specifically for the Indian scenario, it is around 83% of these cancers, they are being linked with the HPV 16 and 18 variant. So if any vaccine, because there are 200 types of HPV variants, if any vaccine, even the bivalent vaccine, if they cover HPV 16 and 18, still we are able to manage 83% of the cohort, which might not have a cervical cancer in future. So what the WHO position paper globally tells about whether it's a 1-dose schedule, is a 2-dose schedule, it is 9 to 14 years of age, or it is between 15 to 20 years of age, or older than 21 years of age. So latest schedule guidance from CDC, from WHO position paper, from ANTAGI is that even 1 dose of a Gardasil 4 or a Gardasil 9 or a Cervarix vaccines, they give us a lifelong kind of a immunity for with a 1 shot of a HPV vaccine. So this is the current latest immunization schedule which is being followed globally. I will be showing you what the globally how the transition is happening from the dosages schedule. If we see this map of world, where we have a data of 194 countries where HPV vaccine they are being reported, out of which 159 countries they are using HPV vaccine in their program, and they have introduced 159 countries, they have introduced HPV vaccine in their immunization program. If we see out of these 159 countries, almost 89 countries, they have shifted to single dose of Gardasil. Means a single schedule of a Gardasil dose they have been shifted. Though the manufacturer's ideal schedule is a 2-dose or a 3-dose schedule, but the global guidance is coming with a single dose of a Gardasil, which is as efficacious as 2 doses are there. Then is the different delivery platforms through which platform it is being administered globally. Then if we see the left side, lower side, where the almost 30 countries they have introduced a facility based introduction of a HPV program in their program. 89 countries they are doing school based, and many countries they have a mixed model where the facility based introduction is there, where the school based introduction is there, the school based introduction there. So it is there. So it is depends upon the country to country, country to in which scenario, in which platform scenario. So this slide for introduction of slide is important. So this slide is important for all of our audience which are connected virtually throughout the country. Globally, there are 6 kinds of vaccine: Secolin, Varlinax, the Cervavac, then is a dose for Gardasil quadrivalent, then is a Cervavac, Gardasil 9, Cervarix. These are the 6 variants of vaccines which are available. If we see the first 2, the Secolin, Varlinax, they are from China, they are bivalent vaccine. What I was communicating earlier is that they have 16 and 18 variant, which prevents us from the cervical cancer of HPV 16 and 18. So they are equally effective. Then Cervarix, then the Gardasil is quadrivalent. It has a 16 in 18. Besides that, it has a 6 and 11 variants also, which prevents us for the anogenital warts. Then Servavac, it is also having a quadrivalent variants, that is 6, 11, 16, and 18. Gardasil 9 have 9 variants. 6 and 11, they are common for all. That is for anogenital warts. All presentations, they are of a single dose vial. The dose is 0.5 ml being given intramuscular. All are already constituted vaccines. If we see the Gardasil, quadrivalent Gardasil, it is WHO PQ qualified since 2009. This vaccine, the Gardasil, is the oldest one, which has been introduced in the program in 2006 in different countries, and which got a WHO PQ in 2009. Then is a Sequel and Warninex. These are the latest addition in the vaccine, which got a WHO PQ in 2021 and 2024. We have a indigenous Cervavac vaccine also. They have submitted a data to the WHO for WHO PQ. This is also quadrivalent vaccine, which is as of now is a 2-dose schedule for the program. Wherever in the private practice they are using, or some states like Bihar they are using. Though the ICMR is doing a study on this for 2 doses versus 1 dose, that study finding will be coming in March 2027. Then we'll come to know whether even a single dose will be as efficacious as 2 doses. So this is the presentation, how they look like basically. This is a single dose presentation. In a private practice, we get a pre-filled syringes also, and the shelf life for this vaccine is from 24 to 36 months. It has a in a government supply or in a program supply, they have a VVM also, means the vaccine while monitor as we get a vaccine VVM in other our UIP, Universal Immunization Program vaccines also. But in a private practice, the vaccine which is being introduced, they don't have a VVM, and then all they are in a liquid form only. And the last lower side, if you see, these are the presentation, how the carton, how the wrapping they look like for this vaccine, how much space they occupy in the cold chain, and what kind of adjuvant is being mostly common is a aluminum hydroxide, which is a common adjuvant for all. Then is a different product presentations, which kind of efficacy they are providing from 9 to 14 years of age, or for more than 21 years of age. What kind of side effect or a kind of a EFI they have been reported. Generally, they are same as they are being reported for other routine immunization vaccines. And whatever has been presented in the past in the literature, all they have been clarified. They are as safe as they are the routine immunization vaccines. Mostly they are the EFI which has been reported. They are systemic fever, the headache, fatigue, myalgia, irritability, the loss of appetite, nausea, hypersensitivity reactions. Sometimes it is being contraindicated during the then we can take some precautions to rule out which kind of allergic reactions they have in the past. The bottom line, which I want to show, is that there are 2 more vaccines which are in pipeline besides this 6 vaccine. One is Sicolin, which is a Chinese vaccine. They are coming with a nano valent vaccine also, that is Sicolin 9. And another vaccine is being produced through the Russia. That is a quadrivalent vaccine with the Cigardex, name as a Cigardex. They will also be coming in future globally. So there will be 8 vaccines globally in the coming time. So what are the different cold management requirements for the Gardasil or other HPV vaccine which are available in India or globally? They are being kept between 2 to 8 degree temperature, as is kept with the other routine immunization vaccines. If they are very freeze sensitive, they should not be frozen. If frozen, their efficacy, their potency decreases. So we can have a shake test, as we do in a T series of test vaccines for seeing that those vaccines, they are not being frozen during the cold chain system. Then vaccine management, as we do with other routine immunization vaccines. Then is a global safety profile. Almost 500 million, 50 crore doses they have been used globally. And if we see the Gardasil efficacy, the Gardasil potency, the Gardasil the safety profile, almost the A5 which has been reported, they are of mild nature, like pain at the injection site, the redness, swelling, systemic reaction. So this global, basically a global advisory committee on vaccine safety. They have come out with a white paper that this vaccine is as safe. The other vaccines are there, and none were casually related to HPV vaccine. Like initially, it has been there in the literature, like complex regional pain syndrome or a postural orthostatic tachycardia syndrome or premature ovarian functions. But later on, detailed investigation, causality assessment has been done with all those cases like GB syndrome. None of them were casually related to HPV vaccine. So, if we have an experience of HPV vaccine introduction in state of Punjab, Sikkim using in their routine immunization program, both they have used the Gardasil for the quadrivalent vaccine, and they have come out with very good learning experience from the state of Punjab and Sikkim, and the colleagues from Sikkim will be speaking after me about their experience from the state of Sikkim. They have started with a pilot of a Gardasil vaccine, and later on they have introduced in the routine immunization program, and they are using this vaccine. And the HPV vaccine, they have been found as safe in both states of Sikkim and Punjab, as per our past experience. Then country intend to roll out HPV vaccine in immunization program also. The Ministry of Health and Family Welfare already done a capacity building all 36 states and UT till district level in one go only. All state immunization officer, the team, the district immunization officer, and down to the line, the trainings, the capacity building is going on for introduction of this vaccine. The vaccine which we are going to introduce in the program is a Gardasil 4, that is a quadrivalent vaccine. The dose is 0.5 ml, left side shoulder, intramuscularly it is being given. To start with, initially it will be a facility based introduction of the vaccine, will be from the Ayushman Arogya Mandir, the primary health center. The lowest, the place where the introduction will happen is the PHC, then CHC, the sub-district hospital, district hospital, and the medical college hospitals. And initially it will be in a campaign mode for 3 months, with all girls of 14 years of age is to start, because the recommendation is for 9 to 14 years in the country. But we have a supplies according to coming from a Gavi in a limited manner. So we have thought to include 14 years of girls in the campaign mode to start with, so they don't turn up 15 years of age, they don't come to outside the beneficiary cohort, and later on the more number of vaccine will pour into the system. The 9 to 13-year girls may also be included. So for a EG calculation for the field worker is that any child, any girl who has celebrated 14th birthday, has not celebrated 15th birthday, that will be a target age group for the mobilization of girls in the field at the ASHA level, at the Anganwadi worker level, at the field level, to easy to communicate to the parents also, to the school functionary also, in the PTM also, to mobilize that any girl who is 14 years of age, who has celebrated 14th birthday but has not celebrated 15th birthday, that is a target age group for the campaign mode. And roughly by thumb of rule, it is 1% of the total population of that state or a district, which amounts to 14 years of girls. And the vaccination team will comprise of ASHA as a mobilizer, the verifier, the ANM LHV as a vaccinator, Jan Arogya Samitis or Mahila Arogya Samitis or health staff. They will work as a mobilizer or a voluntary in the field. This is the strategy. This has been given to all the state functionaries of the immunization team, that how the rollout will happen. The guidance has been given to all states on this. Now the NCD team is connected virtually. This is for the appraisal of all the NCD teams throughout the country, that this is the program is in the pipeline. All the immunization teams of all state and district, they have been sensitized about the introduction plan, how the introduction will take place in the country itself. Something about technicality of this Gardasil or HPV vaccine. This is not a killed vaccine or a live vaccine. It is basically a non-live recombinant vaccine, having a virus-like particles made from the outer shell of HPV virus, but not the actual virus, who have an antigenicity is being retained. However, the pathogenicity has been destroyed. So antigenicity means they have a capacity to produce the antibodies against the HPV variants. So this would be the exclusion criteria. Girls out of the target age group as of now, the pregnancy. If any child is previously vaccinated with any kind of vaccine, she should not be given the second dose from the Gardasil. Only thing is that if they receive the Servavac, which is a Serum Institute vaccine, if they have got that first dose from the private sector, they should get the same vaccine from private sector wherever it is being implemented. So there is a cross administration of vaccine is not permitted as of now. The make and the company which they got a first dose, that should be given as a second dose. However, for Gardasil 9 or Gardasil 4, that is quadrivalent, this is a single dose schedule. We need not to convince for the second dose. Left arm is being chosen for the girls because these are school going girls, they are adolescent girls. So non-dominant arm is being chosen so that if some pain or swelling happens, so they are doing their household or their homework or school work with the right hand. HPV vaccine may be given as a co-administered. This is a technical knowledge that even if it is being co-administered with the TD vaccine or other vaccine, theoretically it can be co-administered with other vaccine. There is no contraindication for that. And HPV vaccine, we have given the guidance once it is being rolled out in any state. If the other state girls, they are residing into that area or coming for education with their parents, they should not be denied. Finger marking is envisaged during the campaign mode just to identify which girls the immunization has happened. And moreover, for the peer learning, peer pressure also, if the adolescent girls in the school, they show the left index finger as that I have been vaccinated. Have you been vaccinated? So this is kind of a peer learning for them also, and peer motivation also for other girls to come forward for the vaccination. And girls and parents to be advised that girls are not to come on an empty stomach during the vaccination program, because there can be a kind of a syncope attacks, which are basically more of a syndromic nature rather than having any organic issue with that. So why we were just talking about single dose? There is a plenty of evidence from Kenya in 2018, Tanzania in 2017, then India in 2009, 2000 from the Costa and other countries. So because the antibody is they are being retained at the peak level till 10 years of age, basically. Even if a single dose is being given, there is a plenty of literature which I am just showing through this slide. Then antibody level among girls receiving a single dose of Gardasil 9 or a quadrivalent vaccine or a Cervical vaccine, they are at least as high as those in women from CVT or IRC studies. And they a single dose showed almost 95% of the efficacy of all these studies. Though they give us a confidence, they give us an evidence that a single dose is as efficacious as two doses. And in any public health program, if we can save with the same price two girls, then it is better to give a single dose rather than two doses. In public health intervention, it is the cost effectiveness is seen that if the purpose is served with a single dose, why to waste second dose that can be given to another girl to save from the future cervical cancer for that. So once the vaccination will be given in the health facility, there are key messages which will be given to the child or the caregiver or the parents. Wait for 30 minutes, single dose is sufficient. We need to counsel them because people will Google, people will do the research. Basically, two doses is a commercially recommended doses. They are the manufacturer's ideal schedule. They are not the program ideal schedule. So we have to keep as a technical people, these are the manufacturers or the company ideal schedules. But as evidence, as per the WHO guidance document, as per the CDC, as per the NTAGI recommendation, the single dose is as efficacious as two doses. For minor AFI, we can have a paracetamol, we can have a guide them to go to the next higher facility if something persists. All vaccination will be captured through the UWIN only, which we have a portal. And this is my last slide. So once the program is being rolled out, so what could be the opportunities and challenges? Challenges would be that people will Google, they may come out with the negative stories of HPV vaccine, some cultural issues, the religious belief. People may link that our girls, are they sexually active, whether we need to give that HPV vaccine. So in my training and my learning to all states, I always reiterated that never link this HPV vaccine with the sexuality. Basically, you ask at the field level, this is the only vaccine which can prevent the cancer. This is the only cancer which can be prevented by vaccine, which is as efficacious as 95%. So this is a vaccine which is for the prevention of a cervical cancer. It is nothing to do with sexuality. We start discussing and convincing them that we should give it as early as possible because our girls, they are not sexually active, then the discussion and then the verbatim will go in a wrong direction. So and people will come in a defensive mode. So never use, in my whole presentation, never use that it should be given in a sexually reproductive age group or just sexually active girls. Perception of this as a sexually transmitted infection, that can be one challenge. Perception of harms, vaccine cost, it will be free of cost in the all facilities in government setup. So limited vaccines, people may ask, why not you are giving to 9 to 13-year-old girls? So to start with, let us build the confidence of the community. Let us start with 14 years of age so that they don't come as a 15-year, they don't go out of the bracket of the beneficiary. Then accessibility is there with all the PHC, the CSC, the district hospital, the sub-district hospital. And whenever I again reiterate, because in my earlier speaker, they told about the screening part. When the mother is coming for the screening of cervical cancer, I think we need to gain that opportunity. We counsel the women for the screening. Same time, we'll ask that women that, see, if you have a girl of 14 years of age, there is a one vaccine which can prevent from future cervical cancer. Since you have come up for the screening of cervical cancer, there is a vaccine. So you are doing dual purpose. You are doing counseling of a mother for cervical screening, as well as you are promoting a demand generation for their girls also for the vaccination. So we can use that opportunity at all our Ayushman Arogya Mandirs, the PHC, for the demand generation also, because that will be a good opportunity for use of this vaccine. So single dose of Cervavac the study will come by March 2027. Till that time, country has intent to introduce a Gardasil 4, which is already proven as a single dose health facility vaccination, allow both in and out of schools, because some may say that we should start from the schools also. It's a very good idea. But our health facility model will capture all girls which are in the school also, whereas as per UDICE portal, many girls, they are out of the schools also. They can be mobilized at the PHC or a CSC level also. So that is another opportunity to immunize those girls which are out of school girls also. So initially, to start with from the health facility, in the future, if the demand generation comes for the outreach camps at the VHNDs or a sub center or a school, say start demanding that please come and come to our school and do a vaccination campaign. We are liberal and open to that also. But as a step one, to start with, the health facility rollout will happen. Better A5 management. Basically, once we have done a good mapping of all A5 center 24/7 district wise. We had a meeting with all the district immunization officers, the state immunization officer. We have asked them to map all A5 centers also. If anything happens to any child during mild, minor, serious, or severe, they need to be handled very swiftly to the next health facility for A5. The human will use for recording and reporting purpose for all the vaccination program. So this is my last slide. So I want to convey through this virtual meeting with all my colleagues in NCD which are working in this area. Please vaccinate, screen, and treat. Or all these three components are the sure defense against the enemy of cervical cancer. Screening, treatment is there. Vaccinate is another tool which we'll be introducing in the program, where we'll be getting the opportunity of a mother when she is being coming for a screening. Ask her to get her girls being vaccinated with HPV vaccine. Do dual purpose, screen as well as motivate and do the demand generation for vaccination of those girls. So thank you very much for this. And if you have any question, you can just put in the chat box and we'll address all those issues. Thank you very much.
Thank you very much, sir, for taking us through the programmatic aspects and strategies of HPV vaccination and the way forward, and for also explaining different vaccine options, their management, also taking us through the opportunities and challenges and how to address them. The presentation was extremely, extremely useful. Your guidance will be highly valuable for program managers and field teams as we move forward with cervical cancer prevention and implementation efforts. Throughout your presentation, the participants were acknowledging and clapping, and we have also received so many messages in the chat box. Thank you so much, sir, once again. We would like to inform all participants that at the end of the workshop, we'll be conducting a post-session Kahoot quiz. The top performers will be acknowledged by the Ministry of Health and Family Welfare, Government of India, and will be provided the certificates. Therefore, we encourage everyone to stay connected and actively participate till the end. Moving on to another important session, which is on service delivery, capacity building, monitoring and reporting for effective management implementation. Effective cervical cancer, requires a strong service delivery framework supported by capacity building and a robust monitoring and reporting mechanisms. It's my honor to invite Dr. Umesh Mahanshetty, Director, Homi Baba Cancer Hospital, Visakhapatnam, to share his valuable insights on various service delivery models, capacity building, and monitoring and reporting for the effective cervical cancer program implementation. Over to you, sir.
Thank you very much for that kind introduction. Can you hear me clearly?
Yes, sir, we can hear you very clearly.
Thank you. So at the outset, I would like to thank Ministry of Health and Family Welfare for this opportunity. I'm also happy that I'm addressing an August gathering across the country who are involved in implementing several health programs in the country. So the mandate given to me is the service delivery, capacity building, and monitoring and reporting for effective cervical cancer program implementation. Well, I will not go into entire details, but I want to highlight certain aspects of cancer care in relation to the cervical cancer today. What I've shown in this slide are the pillars of cancer care, including NCDs, and many of the speakers have already alluded to this: prevention, treatment, palliation, and rehabilitation. Of course, most of the talks have been on prevention so far. However, it is always important to remind ourselves prevention is for preventing cancers in future. However, there is a huge load of cervical cancer patients who are already in the community who deserve the dignity of treatment, palliation, and rehabilitation. So I will touch upon on each of these what we are doing at Homi Baba Cancer Hospital, what we are doing at the community level, so that it becomes an example for many others. In the pillar of treatment for cancer, I'm sure most of you know that the major treatments have been surgery, radiotherapy, chemotherapy, and recently the recent advances show that targeted therapy and immunotherapy is emerging. And in surgery, robotic surgery is also emerging, so that we can offer a precise, personalized cancer therapy for every patient who walks into a cancer hospital. However, most important for the Indian setting, and not only for India, but also for low middle income countries, is this cancer treatment should be accessible, should be affordable, and definitely there should be measures for cost minimization without compromising the efficacy. And then we should also look at cost effectiveness so that we also work towards Atmanirbhar Bharat. I wanted to quote some examples, and this slide shows one of the biggest example in cancer care today in this country. Uh, Tata Memorial Center has been promoting a hub and spoke model through which a larger population can be covered for comprehensive cancer care in a systematic way, in a pyramid fashion, so that every cancer patient who deserves treatment gets what is the best at their doorsteps. Success story for this: today, Tata Memorial Center have 9 hubs and 3 spokes in practice, catering more than 1.3 lakh new cancer patients being treated at these 9 hubs and 3 spokes today. The second successful model has been a Tata Trust model for cancer care, where the objectives have been accessed through disaggregation, technology-driven integration, standardization of care, and personal and training integrated. And this has been very successful in Northeast India today. The third initiative I like to highlight here is the National Cancer Grid initiative by Tata Memorial Center, where today we have a network of more than 350 cancer centers who treat cancer patients, and through this grid, we are able to uh, cut down the cost of cancer care in terms of negotiating for the cancer chemotherapy drugs to a cost which might be affordable to our patients. It also is involved in education training, it offers virtual tumor boards, telepathology solutions, and more importantly, we also have National Cancer Guidelines for all cancers, which have been adopted in Ayushman Bharat Pradhan Mantri Jan Ayon Yojana, where today most of the patients are getting treated with this guidelines. Coming back to cervical cancer, on the left side is the burden of cervical cancer in 2022 according to the Globocan. And if you see, the majority of the burden is in low income and low middle income country, and to some extent in upper middle income country. But what I've shown on the right side of the slide and the bars in the red project that in by 2045, the burden is going to be increasing. For example, in no middle income country, the burden is going to increase almost twofolds. So is also in upper middle income and low income countries. So what it means is, although many countries have initiated vaccination program, have initiated screening program, we are still going to land up with this high incidence of invasive cervical cancer, for whom treatment has to be offered towards the initiative of cervical cancer elimination program, where one of the pillars is the active treatment, so that most of the cancer patients are cured. For the general knowledge, for cervical cancer, we usually do a staging after a doctor evaluates, takes a biopsy, imaging is done, and more importantly, all the patients are discussed in a tumor board. And in the treatment principles, we try to divide them into early stage and advanced stage. And in early stage, we have option of surgery versus radiotherapy with or without chemotherapy. In advanced stage, sadly, the treatment is only radiotherapy with chemotherapy, and majority of the patients who have more advanced disease only receive palliative chemotherapy, radiotherapy, or best supportive care. And unfortunately, in India, even today, the cervical cancer incidence reports suggest that two-thirds of our cancer are either stage 2B to 4A or 4A to 4B. What it means is we are dealing with high burden of disease, which are more advanced disease, and these definitely need radiotherapy with or without chemotherapy as a major treatment modality. And this is shown in this slide, highlighting that more than 80% of the patients require radiotherapy treatment for cervical cancer, which is reported today in the community. And to these effect, as I mentioned, we have good evidence-based guidelines, not only from Tarun Hospital, but also ICMR has guidelines. And as I said, National Cancer Grid guidelines are also in place, which are useful and helpful in discussing with the patient what's the best treatment option and how this treatment option can lead to higher cure rates. Coming to radiotherapy, we definitely need these big machines which are shown in this picture, and these are nothing but the linear accelerators and brachytherapy machine, which are bare minimum essential for treating cervical cancer patients. And as I said, more than 75% will require these machines for treatment of cervical cancer. Again, a sad story. We are of a population of 1.2 more, in fact, more now, billion population. But the positive news is that if you see these curves, the graphs, the from 2005 onwards and now to 2025, we have more or less doubled the number of radiotherapy machines in the country. Suffice to say that we have, if not sufficient, at least many machines which can treat cervical cancer patients in majority of the regions of India. And if you see on the left side map of India and the dots which have been shown in various states, these are the distribution of radiotherapy machines which are available for cancer treatment. And this is a big sad story in the country, because if you see, majority are located in South India, very few, let's say, in North India, and Northeast India is also minimum in terms of availability of radiotherapy. This will show even in more detail. On the left is the zone wise, and you can see majority of the radiotherapy machines are concentrated in south. And if you see at the lower end, center and northeast regions of India lack radiotherapy facilities for treatment of cervical cancer. And on the right side are the state wise, and you can see many of the states at the bottom, including Northeast as well as other states, have barely one machine for radiotherapy treatment. And what is the need today? This is an article which says that to treat the cervical cancer burden, which is seen in India today, we need more than 1,000 machines still added to be catering for treatment of cervical cancer. To this, I'm fortunate to work with the Andhra Pradesh State Health Department, where we have now National Cancer Grid Andhra Pradesh State Chapter, through which is supported by Health and Family Welfare Ministry, through which we do a lot of the activities which are working towards not only screening, prevention, but also treatment and palliation. And we have this chapter MOU signed, and through this MOU, we are involved actively with the state health for prevention, both primary, secondary, and tertiary prevention. To give one example, this was a pilot study done by our cancer hospital in this region, where we trained 50 medical officers or CHOs as well as MLHPs in this neighboring district. And what we did was, through these training programs for screening of common cancers, we then engaged ourselves to go to the community and screen all the eligible individuals, not only for oral cavity cancers, but also for cervical cancers. And based on the success of this pilot study, we then discussed this proposal with the state health department, and they were quite proactive in working with us. And what we did was, state health department was kind enough to set up preventive oncology departments in all the government medical colleges in Andhra Pradesh. And through these preventive oncology departments, we structured a train the trainers program, both for 5-day training program, over which 17 batches, including more than 700 doctors, MLHPs, nurses, and NMs have been trained. And the model which we implemented was that the preventive oncology department by rotation came to our cancer hospital, spent 5 days with us, and through those 5 days, we held them for both theory as well as practical aspects of common cancer screening programs to be implemented in the community. We also provided them a training material which is which could be used by the preventive oncology department of all medical colleges to in turn go back and train all the health workers in their district by a 3-day training module. And by doing that, then the health workers were asked to go into the community and implement the national program of NCD, so that they could also cater for screening of common cancers. And this is just a picture to show that majority of them came to our hospital, and through these programs, you can see each of the medical college have run their training programs to train the health workers in the community. And I'm happy to announce that by doing this train the trainer program and sensitization program, today we are proud in Andhra Pradesh that more than 18,000 healthcare providers have been trained for common cancer screening. More importantly, as mentioned by Madam in her opening remarks, we also have a referral pathways, which have been defined in detail, which is available to the health workers and the medical officers working at the community level, where what should be done if the patient is screen positive. And based on that, there is a triaging system which has been defined in coordination with preventive oncology department of preventive department of the health state department, and this is working very well according to me. The Of course, the number, I am not going into numbers, but what I understand from the Ministry of Health, the screening program, including survey as well as triaging of screen positive, is actively being done in the community. More than 2.5 crore population have been surveyed and screened so far. I will not go into the details of the results so far. The other aspect of treatment pillar, as I mentioned, is effective palliative care program, which is required to be integrated at a community health service level. And this is very important because majority of the cervical cancer patients do land up with recurrences, do need early palliative care. So integration of palliative care services, whether it is early, concurrent, end of life at the community level, is the need of the hour, not only for cervical cancer, but also for other cancers in general. And if this model is integrated with a similar intention and objectives, the way we did for preventive oncology, I think the community health workers, if they are empowered with both screening for common cancers as well as a module which helps them to implement palliative care at the doorstep of the patients, I think this is going to be a very successful model for not only India, but other low middle income countries and low income countries, where patients would definitely benefit out of these ventures. Lastly, I would like to also inform you that a lot of artificial intelligence projects are being integrated, and this is also coming in a big way in a community healthcare practice. One such venture we have been experimented now in our center with the support from National Cancer Grid and non-government organization called as Navya, through which we have integrated this as a hub and spoke model, Basically, this is nothing but a virtual tumor board which is available online. And again, acknowledgements to the AP State Health Department for supporting this innovative opportunity. And what was the aim of this was that through this AI-based online option, we had two different modules. One is the AI would give an output where once you provide some information, what are the symptoms, what are the signs, what are the tests done so far, the virtual tumor would allow you to give you output suggesting further evaluation if the diagnosis of cancer is not clear. And second is if the diagnosis has already been done of cancer by a biopsy, then it also provides a platform of a tumor board virtual clinic, and the treatment options are provided from the evidence-based treatment guidelines. And what we have adopted in this was the National Cancer Guidelines, because these have been approved by Ayushman Bharat. And what you see in the busy table here is more than 2,500 patients have been tackled at different government hospitals in different environments in Andhra Pradesh. And what we have shown here in this AI-based approach is there is 85% concordance. If I was physically present to as a cancer specialist, what should be done for further evaluation and what treatment should be offered according to the guidelines. And AI-based output, 85% concordance is really an excellent concordance with expert opinion. And according to me, this is going to be an integral part of healthcare in future in India. So finally, before I conclude, I strongly believe, and I would like to leave this statement to you, none other than Mahatma Gandhi, that man often becomes what he believes himself to be. If you think that I cannot, definitely you become incapable eventually. However, if you are on the contrary, if you believe that you can do it, you will acquire the capacity and you will take that challenge, and you will start whatever you wish to do. So with this, I would like to thank for your kind attention, and I would be happy if there are any questions, and feel free to contact us. We'll be more than happy to help anybody. Thank you.
Thank you so much, sir. Thank you for clearly outlining the service delivery pathways and the importance of system strengthening. Also taking us through the referral model that you have shown in the presentation. The Tata Memorial Hospital has been pioneer institute as a tertiary care institute, and it has been a mentoring institute for various primary and secondary hospitals. Thank you again, sir. Thank you for your insightful presentation.
Thank you very much.
Now we'll move to another important presentation. As we know that learning from state is extremely important for cross-learning and replication of best practices. I now invite Dr. Sangeeta Pradhan, who is the state nodal officer for NCDs for the SKIM, to briefly share the state of SKIM's experience in cervical prevention, screening, and care. Over to you, Dr. Sangeeta Pradhan.
Yes, madam, joined.
Ma'am. Hello.
Yes, you are audible, ma'am.
Can you please share the slide from your side?
Yeah, we will do that. Request you to please, complete in 10 minutes as we are running out of time.
Yeah, actually, thank you for the invitation. And most of the things are covered already by the experts. So I think I do not have to speak much. I'll just say some points regarding what we have done in our state.
Okay.
So regarding, we have done a pilot project on HPV DNA cell sampling for cervical cancer screening in collaboration with ICMR. That we started in 2022 and was completed in 2024. As all the CHOs have joined, I would like to just tell them that our nation is working towards the global cervical cancer elimination strategy. For this, we need to achieve the target by achieving 3 pillars. That by 2030, but this is not possible by 2030. But by 2030, we can just start to think about it. So we have to achieve 90% of human papillomavirus vaccination. And this, our state has already started in 2018, and we have been able to achieve 97%. And in between, due to restriction of fund, we could not vaccinate. Otherwise, the vaccination is added in our routine immunization. And we need to have 70% screening coverage with high performance test. And on this topic, we were lucky to have an experience on screening cervical cancer by self-sampling. And the third pillar is 90% women who have been tested positive with the HPV DNA testing, they should be treated for precancerous and cancerous lesion. And WHO also recommends that HPV DNA detection rather than VIA and cytology. So for cervical cancer is the only cancer that can be eliminated by achieving this 90-70-90. So the threshold is for elimination is if we have a cervical cancer less than 4 per 1 lakh women. So I come to my what we did here. As you know, everything is already covered, so I need not stress on this. So next. So this is already said there are 3 procedures: Pap smear, VIA, HPV DNA testing, through which the HPV screening can be done. And we had done a pilot project for around 10,500 samples. And there are 3 tests which are done: HPV DNA, VIA, Pap smear. And the HPV DNA testing has been shown, more acceptable to the people. It detects high-risk HPV infection early before cancer develops, and it is most sensitive method, allows self-sampling, and WHO recommends primary screening test as HPV DNA testing. BIA screening is there in the national program, but then this is a low cost but operator dependent. It depends upon who is doing the visual inspection. It has lower sensitivity, and it depends. So many cases can be missed. And visual inspection acetic acid at the population-based screening is very difficult, because in our hilly areas, people have a less health-seeking behavior. Health-seeking behavior. They do not have that. So in order, people do not come to the hospital for VIA screening, health checkup. So in our state, our CHOs along with other staff, they they usually conduct outreach areas screenning at the popular hard to reach area screening, where this self-sampling kit HPV DNA testing was found to be very beneficial, because at outreach areas we do not have a privacy or proper place to do VIA, and also we do not have a place to sterilize the equipments after every VIA test is done. So we came, for us, the HPV DNA testing by self-sampling was better. And regarding the Pap smear, which is done mostly by the gynecologist, this is moderately sensitive, and this requires lab and trained cytologists, and results take longer. So precancerous lesion, it seems it is most of the time missed in the Pap smear. So what we did was, after testing, if the test was positive, then they were subjected to VIA trials, and if VIA was positive, the treatment assess positive, then they were treated with thermal ablation, and those were not eligible, then they were referred to higher centers for further investigations. And those who were negative for VIA, then they were called, they were HPV positive but VIA negative, then they were followed up after 1 year. And those who were HPV negative, then they were rescreened after 5 years. Next. So this is a project, I said already, we completed 6,000 was the sample size, and later on we had extra samples, which we did for 4,500 more. So the ASAs were trained, staff nurse, MO, gynecologist were trained for different procedures. Next. So the findings which we got in the self-sampling test, where the total positive case was 907. The SPAB positivity test in the urban area was found to be around 10 to 11%, whereas in the rural area it was less, 7 to 8%. Then total number of VIA done was 825. All the HPV positive usually do not come for VIA because most of them, after knowing that they are HPV positive, they directly go to the gynecologist. They don't come for further checkup and further treatment. So there were some people who we could not motivate to come back for the follow-up. And the VIA positive is more because VIA was done on the HPV positive cases. And among them, we could send 16 of them for leap, 19 of them for leap treatment, and 19 we referred for colposcopy. And 4 of them were diagnosed with cervical cancer and they were referred to higher center. And women who have done hysterectomy, 7 people, they were, they themselves went to the, some of them were diagnosed with cancer and they were underwent hysterectomy. Some had precancerous lesion, but they preferred to go for hysterectomy. And this is a coincidence. 3 people who were suffering from infertility could conceive after this treatment with thermal ablation, after they were positive. So, this is a very minor thing, but then we had taken urban PHC Gantok and Phodong CHC. We could, reach this target 90, 70, 90 pillars in one urban PHC and one sub-center. So one PHC and one urban PHC. So this is achievable. But then the problem is that this procedure is very expensive. We need a lot of fund, and this we could do only because that it was a ICMR funded project. Next. So key drivers for successful implementation. What we require for successful implementation of this program was self-sampling was acceptable, then VIA among the women, and the community engagement is very important for any program to be successful. Community engagement is very essential. So ASAs were there who were counseling and they were mobilizing the people for this test. And strategic coordination, strong partnership between state government, ICMR, and implementing partners like Japaigo, Chai, they were there to help us, and Kaijani also. And service delivery model, decentralized sample collection, where the sample, initially the samples, sampling kits were given to the ASHAs, but to collect the samples, but later on that was not possible due to the difficult terrain. The samples were not collected by them. So we had to do it on a population-based screening base. Next. So these are some, the challenges was in hilly areas, we have a difficult terrain. That's why the ASAs are not able to travel frequently carrying the samples to the PHC. So that was not possible. So we did it in a population-based screening type. And transportation in our place is very expensive also. And health system constraint was limited availability of trained person, competing priorities on the NCD program where the program is more focused on hypertension and diabetes. Ensuring timely follow-up and treatment was a problem in some cases. And social and cultural barriers, stigma associated with cancer detection, fear of cancer detection, all those were challenges. So fear, then low health-seeking behavior that I said. So now we have submitted one proposal on cancer prevention in Sikkim, proposal to ICMR, DHR. So if that gets approved, then we will be launching a cervical, cancer prevention and control program project in our state. So in that we have included sample screening for cervical cancer screening and other cancers along with stomach cancer, as it is very high in our state. So that is the way forward. So if the program gets forward, then we will be doing further test by this procedure. And I think it will help us to try to eliminate cervical cancer in our state. Next. I think that's all. So this is just about the test, a hybrid capture test. And these are the pictures where colposcopy training is done, ASAs are trained, and this thermal ablation was provided to us by Chai, and this is provided to all the PHCs where thermal ablation training was done, and the staff doctors and some of the staff nurse also, they were very good at performing thermal ablation for the HPV positive patient who were fit for thermal ablation. Next. So these are some of the pictures which we, did. And this was the stakeholder dissemination meeting we did. Thank you. Hello?
Hello.
Yes.
Thank you.
So-
Thank you so much, ma'am, for such an incredible work and taking us through the field experiences of STEM. It's really helpful for other states in terms of replication and in terms of understanding the opportunities and the best practices from the SICM. Now, I quickly move to the state
Thank
of
you.
Telangana. Thank you, madam. Thank you. From the state of Telangana, I now invite Dr. Vasi, who is the state WHO consultant, to share Telangana's experiences related to cervical cancer program implementation. Over to you, Dr. Vasi. I would request you to please complete in another 5 minutes.
Yes, Ashish, as you have suggested, I have cut down the presentation to very limited slides so that we can abide by the timings and proceed with the remaining part, that is the Kahoot and other things. So this scenario, I think it has already been repeated more than once, so I am skipping this just to emphasize again the importance of screening and early detection, because it improves the survival of the patient, which has direct mortality benefit. This is one of the few cancers where early detection is very important. For that purpose only, we are trying to learn from each other. So what were the efforts specifically? I will like to summarize in these 6 points that we had a very structured capacity building program. And for this capacity building program, right from the first TOT of the master trainers, we had support from the Regional Cancer Institute, which is the MNJ Cancer Hospital, which is the apex hospital in the state of Telangana. And the team of oncologists and gynecologists has trained the master trainers. From each and every district, we deputed 3 female medical officers and 3 nursing officers or the staff nurses, which formed the team in their respective districts, and then cascade of trainings were being conducted for VIS screening. Then risk-based and population-based screening, depending upon the risk scoring of the likelihood of a suspect case, instead of directly going with the VIA, because it has multiple barriers, first we categorize the patients with having risks based on the questionnaire, and then mobilization was prioritized for those females. Then we have another state level initiative, which is by the name of Arogya Mahila, which was launched on the Women's Day. That fixed day opportunistic screening is being done by the female providers, making it a female centric, women centric approach and a comprehensive package of services on a fixed day. Every Tuesday in the week, we are providing the dedicated services for the females. In that way, the other barriers which are there, we were able to have a better outcome in terms of the female footfall. Then strong referral and follow-up mechanisms. Every suspect, we made it sure that from the remote areas, at least ASHA worker was accompanying for the further diagnosis in the tertiary care centers in the district hospital. Then regular monitoring and review of the program, like from the state level teams, we have made a mechanism in which periodic reviews are being done, and in the review all the 3 verticals like the primary healthcare, secondary healthcare, as well as the medical colleges were involved during the review, and community mobilization and the demand generation. So basically what we have done is sticking on to the basics, and with a little bit tweak, that is innovation in the form of the making the services women centric under the banner of the Arogya Mahila, which has given us the good results. The challenges were low awareness and acceptability of the cervical cancer screening among the women, then cultural and the social barriers, particularly for the pelvic examination, making it like comfortable for the patients was the priority. So wherever it was possible at the PHC, ensuring the privacy and other things, those arrangements were made. Then staff turnover. This was one of the major challenge, that all the trained staffs who were the staff nurses, once they got the regular jobs or other vacancies which were there, the availability and the continuous availability of the trained staff was the major challenge. And then dropouts from the patient side, in like even though if people were aware and acceptable for the screening purpose, But again, the fear of diagnosis, the cost, indirect cost, particularly in the terms of further diagnostic evaluation and the distance from their place of residence, these were the challenges which we have faced. Then main lessons learned were trained workforce is the foundation for the effective and quality service delivery. Then women-friendly platforms improve the acceptability and increase the service uptake. And decentralized care strengthens the continuum of care by bringing the services closer to the community. Then stronger referral systems build public confidence by ensuring timely diagnosis, treatment, and follow. So this was the brief presentation from the learnings which we have witnessed in our state. Thank you for giving this opportunity.
Thank you so much, Dr. Vasi, for completing in stipulated amount of time and for taking us through the efforts which the Telangana state has taken. Telangana is one of the states which has completed the screening targets. As you have mentioned, the capacity building was at its core. Thank you for those insightful field insights, from Telangana. Thank you once again. And I would also take this opportunity to thank all the experts. Now, we will now proceed with the post-workshop Kahoot quiz. I request all participants to actively